Megan Kruse, Director of Breast Medical Oncology and Medical Director of the Clinical Trials Research Unit at Cleveland Clinic, and I'm here today with my colleague, Dr. Tweed.
Hi, I'm Dr. Carol Tweed. I'm a breast specialized medical oncologist in Annapolis, Maryland, also participating in the Sarah Cannon Research Network.
Thank you for being here today.
Thank you for having me.
So we're going to talk about the role of endocrine therapy in the hormone receptor positive metastatic breast cancer setting and the concept of emerging resistance patterns and how we deal with that and what it means for the patient's treatment journey. A lot of this conversation comes up because of the data we saw from SERENA-6 and where we hope camizestrant might fit into our treatment paradigms. So to get the conversation started, why don't you share with me some of your response when you saw this data and what you thought it might mean for your clinical practice?
When I first saw the data from SERENA-6, I was enthusiastic. I would say I was perhaps more enthusiastic than others off the bat about the notion of detecting resistance prior to clinical progression. When you practice breast oncology long enough, you remember the days where we had very few drugs and just sat watching tumor markers rise and not really knowing when to step in and often seeing a patient become symptomatic before we recognize the need to change treatment.
Mm-hmm.
So the notion of improved outcomes in a patient or perhaps an improved life experience by detecting molecular changes before clinical progression, I was very enthusiastic about.
Mm-hmm.
Yeah.
So it sounds like this was not a new concept. It's something that clinically you were thinking about as you saw patients and trying to get that look behind the scenes of what was actually happening with the tumor, that the scans only got you so far.
Yeah, I mean, I think we torture the scans, I always say. We'd keep looking and we'd bring it to conference and we'd get a different type of scan. Maybe this was not showing it, but maybe this will. And in reality, the vast majority of the time, when we would see certain lab parameters change before a patient would declare either clinically or radiologically progression, we knew what was coming.
Mm-hmm.
It would be an exception to the rule that progression was coming, yet we would hold, and I'd say sometimes put our head in the sand because we didn't have data to support earlier change. So this has been something that we've been talking about for decades, really, in breast cancer.
Right. And so we've felt that we should be making earlier change, and maybe we were limited by our resources throughout the years. Now I think the situation's a little different because perhaps we have ways to address our concerns earlier on, which leads to the point of how soon do we change? Do we, how soon is too soon?
Yeah. I think that there's a lot of discussion about this and people are not all in agreement, right? I think that's clear. I think partially because we need more data over the long term. There are confounding issues, subsequent treatment lines, what endpoint we should be looking at. That I think people get stuck in the weeds on some of this. But what we aren't anymore living is this paradigm of we really have so few treatment options that we don't want to burn them out without an outcome proving that it's worth changing, which was the old paradigm. And I do call that the old paradigm because I don't think that's the proper way to look at the clinical management of metastatic breast cancer anymore. We have a lot of treatment options, and many of them are very personalized to the patient and the tumor's molecular patterns. And so we should feel comfortable considering switch before a patient has to psychologically or physically experience progression if there's no overt harm in that intervention. And how one defines harm is, I think, what we're going to have to get to. Is harm financial? What is that now, right?
Yeah, absolutely. Yeah. I think of that a lot. You know, many of our patients in the early stage setting will ask us, why do I have to wait until I'm symptomatic? Why do I have to wait until something bad happens? And in the first line hormone positive metastatic setting, I think it's very analogous because these patients are living for hopefully a long time on tolerable therapy, which we want to prolong that as much as possible, but we also don't necessarily have to wait until the other shoe drops and they're sick and we're trying to reel that back in and make up ground that we feel like we've lost because the therapy has been on, but just not doing what we wanted to do.
Yeah, no, I think, and when you practice medicine, right, we carry certain patients in our head. And those faces, as we talk now, those faces appear in my head when I think about symptomatic progressions that really we should have switched sooner.
Yeah.
But we didn't have survival data to prove that that was the right thing. We towed the line. We did what we taught others to do.
Right.
But yeah, I think that we are not just emerging. I think we have emerged from that. And now what we need to think about is how are we watching for progression in the molecular sense, and when is the proper time to act on that, not perhaps if it's proper to act on that. Yeah.
Right. So it sounds, based on that statement, that you believe the testing that we have available right now is meaningful to detect certain mechanisms of resistance. Because in that situation, especially with ESR1 mutations, it's a when the resistance becomes problematic, not an if the resistance becomes
It is. I mean, we have, and that's the great thing that, for example, Serena-6, like it's a data mine. It's not just the outcomes from that trial that are helpful for us. We see in that and other trials where we've been able to see data regarding ESR emergence, or I should say estrogen receptor mutation emergence in actively treated metastatic estrogen receptor positive patients. What we see is 3 to 7 months. You're going to see that mutation, and within months, not a year, months, they're going to experience radiologic or clinical progression. So now that we have those data, there's really no question what's going to happen. Then that actually is a lovely time period where one could think, what is the next step before there's symptom? Is it time to change to something that targets that mutation? Is this the window for a clinical trial where we're not assured of an outcome in an asymptomatic patient? There are a lot of new windows that will open up because of this.
It gives us the opportunity to start thinking and planning and acting long before we were ever able to. And I think it also leads into our decision making in the second line for these patients, which is so complicated. And, you know, we don't have the data that really reflects our modern standard of care in many ways, and we don't have answers to the sequencing questions we want. And I think inherently we're still struggling with picking out who is the best patient for endocrine-based therapy in the second line. Every trial we have shows that we lose response and patients get sicker within the first 8 to 12 weeks, right? At least a good chunk of them. And so I wonder, as I look at these first-line studies like Serena-6, where we are getting information about those patients with early resistance, like would those curves look different if we intervene a little bit earlier? And so it's almost proof of concept, I think, in many ways, that although we have very active drugs in the second line, how do we move the needle for those patients that could be on first line therapy longer and then look better in a second line trial versus, you know, not acting in the best way for them in the second line early on?
I agree. And this is a point that's important to make that I think is often missed, which is what you're alluding to with once you have endocrine resistance and you're moving to a second or sometimes a third line of endocrine therapy in these ER positive, not HER2 amplified patients, right? You see the fall off. So if somebody just looks at progression-free survival, then the statement's going to be no treatment looks good here, right? So when you're talking about fulvestrant monotherapy, an oral SERD monotherapy, if you don't look at the data in the way that perhaps would be more helpful, which is looking at 6, 12, 24-month progression-free survival potential, you miss the fact that there is this subset of endocrine-sensitive patients still, right? And then you see that there are benefits to some of these treatments that target the mutation. But since you have that symptomatic fall off of the majority of patients, it looks like second or third line endocrine therapy doesn't work, that you need to jump more quickly to parenteral therapies, chemotherapies, antibody drug conjugates, and really that's not the case. If you could capture that subset of patients, perhaps, I don't know, 30-ish% or more patients who really are still endocrine sensitive, and then avoid exposing those patients who might be falling out and becoming symptomatic quicker. If you're following me, I'm kind of seeing the graph in my head of progression-free survival in the second-line oral SERD trials. You're going to do those patients better, both sets of patients. You're going to do the truly endocrine resistance patients better by not exposing them to something that just allows them to have 2 to 3 more months of maybe an endocrine therapy, but really just progression and symptoms, and really pull those other patients who are endocrine sensitive through without having to experience progression for much longer. And so I I think it's important, though, that then we all, as a community in breast oncology, continue to really focus on the discussion of endpoints that matter. And every time someone talks about a median progression-free survival and subsequent endocrine therapy lines of 3 to 4 months, I think that's missing that point. Yeah.
Yeah. And I think about that as we talk about extending first-line therapy with a paradigm like what was seen in SERENA-6, right, where we're actively testing for that resistance mechanism and then acting on it when we find it. That's where I wonder if we'll see the value in extending first-line therapy, acknowledging that it is some switch that's happening within that line, right? It's really not continuing the same therapy. But I wonder if for our patients that experience is such that they are on the same type of therapy. You know, it's still oral, it's still targeted, it's non-chemo.
Yeah.
And I wonder if that's what really matters, not so much that it's AI versus SERD, but that it is less complicated, less toxic in many ways than what eventually they'll get to down the road.
No, I think that's the case. And I think, you see that in the global health and quality of life data that really are not to be dismissed. We do still work in this world of oncology where people are confounded by discussions about quality of life outcomes because most of the people who develop those tools are not the people like us who receive the data from them.
Right.
So we don't know how to troubleshoot analysis of those outcomes, right? And I think that's something that we need to keep talking about. But when you see that the patients generally are feeling better and perceiving a better quality of life for many, many, many months, when you act on a mutation before a progression, i.e. SERENA-6 paradigm, that's very hard for me to disregard. I also think that there are many questions we're not going to get answered, and that those are often the questions that people will invoke when resistant, perhaps, to thinking about changing just for an emerging ESR mutation. And the problem we're going to have is these patients who do well on the first or maybe blend 1-2 line therapy, however we're thinking about a switch, they're going to do well for potentially years. And if that's the case, they may not end up seeing other therapies patients in a comparator arm C, and then if people are holding out for survival, or even sometimes second progression-free survival endpoints, it's going to be tough to really interpret that because, an example, right? So we have from Destiny-04, we have survival data, right? So we know from the Destiny-04 trial that those patients who saw TDXD had longer overall survival. We haven't seen that yet with Destiny-06, but maybe just immature, right? But and so we know that's going to confound an arm where people are switching at the time of clinical progression sooner to an ADC than if they perhaps were just switched the time of an ESR mutation and had a longer time on that first line endocrine. And so you're going to mute survival potentially. We don't know that, but that's just getting into that realm of, I think it's going to be tough to know more than we know now. And what we know now is that if you switch at the time of an ESR emergence, the patient has a longer and, quite frankly, better experience of first-line therapy.
Right.
Yeah.
And I think that's what's tricky. If you're resistant to thinking about applying this approach right now, it's almost hard for me to see an endpoint that will resonate.
That's
because I think
better
you
stated
can
than what
always
I
go
said.
back
Right.
to,
Yeah.
Where
Yeah.
the trial may have, quote, fallen short of how we would ideally do things, but it's not the practicality of doing things. And I guess the question in my mind is, does that change the validity of the strategy? Which I'm
Right.
not sure that it does. I think scientifically, the idea of finding resistance early and acting on it rather than waiting for it to get worse just makes sense.
Yeah, it does for me too. It's what's interesting to me is when the first publications and even just kind of lay press or financial press discussions where some of my patients will get their questions for me who monitor those publications. When that first came out, my informed patients came and asked me for serial ESR monitoring. These are not medical kind of professionals. These are people who just read about it and it made sense to them and they felt it met their goals.
That's a great perspective because I think a lot of the resistance we've heard is about the systems level factors, right? What does all this testing mean financially? What does all this testing mean for the practice workflow? What does it mean for the patient experience of treatment? But I think what's amazing about what you just said is that all of those factors seem overcome when the patients are just sort of assessing their options and saying, how would this be beneficial to me?
And it's really, global cost of care.
Yeah.
I'm in no way saying that's not important. It's very important. But practically, there's no change in the workflow that I see. We're already getting labs at these intervals.
Right. Testing every 2 to 3 months is what we're doing. We're scanning at that interval. It fits pretty naturally into the clinic flow.
I think it does.
Yeah. And I think in terms of accessibility of liquid biopsies, it's only gotten easier and easier over time.
It's a really basic part of our workflow, at least in our system.
Yep. Same for me. And I, as I've talked with other members of the oncology community, it sounds like that's become a more universal experience, that where this liquid biopsies may have once been a challenge, that has become less of an issue in terms of accessibility and payment issues and things like that. So one of the questions that I think comes up when you look at that quality of life data, because that quality of life data really stunned me actually when I first saw it. It's a big difference.
It is a very big difference.
In favor of the switch strategy and in favor of the camizestrant. Can you talk a little bit about what you think that impact is physically, emotionally, and psychologically on the patients who are going into this routine testing?
Yeah. Again, I mean, you have to, if you get really granular, if one does not switch as per a molecular emerging resistance paradigm like SERENA-6, then what you're doing is you're saying to a patient, you're going to one day get a call from me with your scan result. That's bad news. And that day is imprinted in the mind of that patient.
Absolutely.
They are at their kid's ball game when you make that call, right? Or they're at their kid's ball game stalking the portal looking for that result. Either way, that in and of itself is a traumatic event, not physically, but certainly psychologically. Now, if a patient becomes symptomatic, which is not unusual, because at this point, if these patients are progressing, it's often going to be symptomatic bony progression. Then you're scrambling with that. Are you waiting for the next systemic line to kick in? Are you radiating that site? All of this is a disruption to the patient in terms of life process, psychology, and then clearly symptoms if it's symptomatic, which is, amongst the most troubling thing that can happen. But you're also exposing then that patient who you wait until clinical progression or radiologic progression, and then you switch to something else. They're seeing more, I guess I would say, lifestyle impairing treatments sooner than what we see in the camizestrant switch arm in SERENA-6. So they're seeing an ADC sooner. So then they're seeing their 30 to 40% potential for alopecia not protected by cold capping sooner. They're seeing infusional therapy sooner. They're getting a port sooner. They're seeing nausea, asthenia, all these things sooner. And that is sooner and continuous. So even if that next line option is one that has a durable response, which is great. Like, we celebrate the fact that we have in this population ADCs, multiple ADCs, right? That offer sustained benefit after endocrine resistance develops. But once they're getting those, that is a whole different life. So that's what is wrapped up in that quality of life, that global health. It's pain, it's fatigue, it's the process of being a patient. This may seem obvious, but when you take one individual through the process, and those stories of every visit and call and result are in your mind, you see the impact.
You do.
And if you get a lab result that says, oh, okay, the ESR mutation's here, it's okay, we knew this was going to happen. Let's switch before we have a problem. That seems much more palatable for a patient.
Yeah. I think there's some ownership and power over it that happens for a patient.
That's
when
well
you say
stated.
we're actively looking at for this. We know we're going to deal with a progression at some point in time. That's something we share with all of our patients from the very beginning, right? But I think knowing that you can then do something about it. If we were looking for these same mutations and we didn't have something we could do about it, that's a much harder conversation. I think many of us would not be interested in doing that. But here we are kind of shifting and saying there hopefully is a clinical benefit to you. And we all want that to translate into longer life. And maybe we don't know that right now. But I think translating into the better quality of life, the peace of mind, until you were walking us through so nicely of what that patient experience is like and what the clinician experience is like, I forgot from the onset of symptoms, our patients often know before they see us, right?
Yeah,
So they've been symptomatic for a while, then we have the scan, then we get the result. That's traumatic. And then we're waiting for the new medicine to arrive, and that waiting period is torture. And so thinking about smoothing that all out and just doing it in a more controlled fashion.
And then now there's a whole another, and it's really exciting actually, because nothing in our field ever is boring, because then there's this whole next line that there's no answer to it.
Right.
I'll start talking about. But for example, so if we do this, right, and we switch someone to camizestrant at the time of the mutation emergence. So then when the patient progresses, you still have your options for targeting their AKT, P10, PI3 kinase mutation, which you're traditionally going to be pairing with an anti-estrogen.
Right.
Now we have this explosion of options for which anti-estrogen. Are we going to be doing that next line now with a different oral SERD, pairing with a targeted agent? Are we going to be using a PROTAC if it's approved soon? Are we? So the space is going to look very different before we have the outcomes even from this first trial completed. And it's going to get even more confusing, I think. Because it's not really entirely clear how we're going to start pairing all these agents.
I completely agree. And I think that's one advantage to the strategy as well. I think a lot about the decrement in quality of life coming from when we switch to chemo, when we switch to ADCs. But some of these targeted oral therapies are not easy on a patient. And so many of my patients will say, I loved my time on X CDK4/6 inhibitor, whatever that is of choice. And they're like, can't I still have it? Can't I keep going with it, right? They have so much faith in these drugs. And I think that's one of the other things that we can do, right, is say, it may be that part of your regimen that's still working, but it's this other part that looks like it may not be anymore. So, we can keep your favorite drug and we'll just switch this other part out. And I think that's reassuring because people already buy in.
And probably we're eking more time out of the process as well, which is one of our major goals still.
Yeah. And so going back to some of the hesitation about adopting this strategy, I think you and I both have a lot of enthusiasm for it. I think we see the scientific advantages, but also the patient care advantages and the quality of life advantages. Is there anything about the trial design that makes you stop and pause in your implementation of this, or things that you could hear your colleagues saying make them hesitate that you would want to adjust the thought process?
It's interesting because the answer easily is actually no. I think it was really beautifully designed. A lot of times by the time we get results from a trial, we already know enough to know that the trial was poorly designed. Or even as I'm still enrolling onto a trial, I think, come on, now we know
I
it
wish
should be.
we had done X, Y, or Z.
Right. In this case, no, it was really well done. It was, you had to have at least 6 months of treatment. So you're not doing excess testing for ESR emergence at a time it's very unlikely you're going to find it. The interval of assessment every 2 to 3 month blood draws, paralleling your scan interval, is exactly what I would have wanted it to be. The randomization to continue the existing treatment versus just switch the endocrine agent to camizestrant while continuing that baseline CDK, all of that is what I would have wanted this first Sentinel trial to be. There are things that we're going to wonder, like what happens if we switch the CDK to a different CDK as well? We know they're different drugs,
right?
Or am I saving that for later? So I think that's something that I think about now, and I think that the when this trial was published, the authors spoke to it as well, like it would be nice to know if switching the CDK with it is further helpful. But then we also have that cumulative gain concept we always think about, where we can always do that next with a different oral agent.
Right.
Other than that, and I wouldn't have wanted it to be in there in the first trial, no. What about you? I mean, are there...
Yeah, I think very similar. I view this as, again, proof of concept, a platform to start, right? To prove that this is leading in from what we saw in PATA-1, and hopefully with drugs that are easier because they're oral. Camizestrant, I think, having the major advantage over fulvestrant in the route of administration, but hopefully also in terms of actual activity at the estrogen receptor itself. I guess the only thing that I would be curious about is what would happen in the control arm if everybody got oral SERD in subsequent lines.
That's the problem.
But this is... I think it's a very hard critique of studies because in order to get the work done and move the field forward, we know these studies are global, right? We know that the access to drugs is different. And I would love to see that mandatory crossover, but sometimes it's just a challenge to do it.
And there's hesitation, right? So there were some really nice abstracts at San Antonio this year. So I guess that was San Antonio 2025, where people just published their queries of practicing oncologists and also research leaders and said, in these scenarios, what would you do? And the point that came out of that, which we know in practice, is this. Sure, it would be nice to see that crossover. But by the time somebody's symptomatic or truly radiologically progressing, very few people are comfortable using monotherapy with an oral SERD because those progression-free survival outcomes are low, even though, as we were talking about earlier, that's just reflecting those that aren't going to be responders. They're still really lovely responders. And so when they published these abstracts, and I was looking at them at San Antonio this year, it was reflective of the way that I think. If somebody is near symptomatic or symptomatic, oral elacestrant monotherapy or any oral SERD monotherapy at that time makes you nervous because the response potential is low. The median progression-free survival is low. You worry that you're basically going to spend the time that we used to spend just giving someone fulvestrant, knowing darn well they likely were progressing, and then waiting until the patient's even worse off before you change, right? And so because of that, that uptake is not going to be the same as if the uptake is at the time of a mutation emergence. I think in practicality, a lot of people aren't going to be comfortable doing that, if that makes sense.
It absolutely
and then
does.
They switch right to an ADC, which then again confounds the comparator.
It's an interesting, because it's the same criticism that almost proves why this trial was actually done well.
Well, that's a good point.
Because we allowed, we didn't wait for that. We intervened when we thought we could and meaningfully make a difference before it got out of control. And you didn't wait until people were uncomfortable and maybe losing the opportunity to get an oral SERD, right? I mean, I think we're still in a world where oral SERDs are not our first-line therapy. Maybe that will change by the time we're all continuing to process this data. But as it stands right now, you have this window of opportunity that's in the sort of 1+ line to second line. And if the cancer has really gotten out of control and it's more aggressive, are you even going to take the risk that if you've misjudged that endocrine sensitivity, that the patient is going to be worse off? And what does that mean for their ability to receive that next line therapy? Thankfully, I think many of our patients are in positions where even if we're wrong with our decision making, they can still go on to get that ADC. But there are going to be some that don't have that opportunity, right? That we don't predict what that progression looks like. And I think giving ourselves the ability to retain the right to introduce the oral SERD when it's safe to do so, that's probably the best part of this approach.
And particularly now, because soon we're going to have results from all of the first-line trials, right? Evapar and Serena-4. And so if that puts an oral SERD into first line, which is going to be further complicated by the adjuvant trials that are going to be resulting at the same time, right? So who knows? But for now, what we have are, in my mind, our best data for quality of life and progression-free survival rest in using your oral SERD at the time of immersion of this mutation. Now, and we all accept that that's going to change quickly because we have so much more data coming soon. But right now, it's hard for me to see why not.
And I think the other thing we haven't touched on is tolerability of oral SERDs, right? They seem like a great class of drugs. Can you speak a little bit to the experience of your patients of being on oral SERDs and what's great about it?
I can. So I've had a privilege of having both Cambria 1 and Cambria 2 trials for my patients to enroll onto in Annapolis, and it's great. By and large, one of the most enthusiasms patients would have for going on to the trial was the potential to get off the aromatase inhibitor that was causing them arthralgias. And most of the time I see that patients feel better. Now, what's interesting is that isn't necessarily reflected in the published data. Like, for example, the recently reported Lidera data, where
Right.
arthralgias were pretty substantial. And again, they're all different agents, right?
Yep.
But what I tend to see is far less arthralgias. And then the more commonly discussed bradycardia, that's asymptomatic and honestly a non-issue. The visual changes are a minority of patients, go away with time. They don't bother the patient. It's not structural eye damage. So really the reality is the experience has been truly actually universally positive.
That's wonderful.
And in my less, my smaller number of patients exposed to other oral SERDs in the metastatic setting at this point, it's a similar experience. So I've had the privilege of using elacestrant or imlunestrant in the metastatic setting, and those patients do well too. I will say there's some more nausea with some agents than others.
Yeah. Yeah.
But the truth is these are great drugs to use and certainly better than getting bilateral intramuscular gluteal injections.
Absolutely.
Yeah.
I don't think we will be sad when the fulvestrant days
No.
go away.
My patients coming through the door of the clinic, people always know it's one of my patients or one of our breast patients because they'll have ice packs tucked into their pants.
Right. Right.
Yeah.
And actually, I mean, that's a tangible benefit of being able to manage,
It is.
you know, manage with a dual oral regimen for a longer period of
Yeah.
time without the need for infusion, without, you know, having to stop to say, I was planning to travel on X date, but my
Well, that's-
Faslodex injection is due.
Right. The working patient, the mom, anybody who has anything. Right.
Yeah.
All of that
Any
true. Yeah.
responsibilities,
All of
whatever they
that
are.
true.
And it's so funny to me as we think so much about our core tenets of oncology of, yes, lengthening life, but really improving life.
Yeah.
Most of our conversation has really been about improving the quality of life and allowing our patients to have an easier experience, a more meaningful experience with less disease-related complications.
For sure. There's a quote, I think it was Atul Gawande who said, you know, everybody has goals and those goals change. So you have to keep asking the patient. Because when patients are first diagnosed with metastatic disease, I find, there are exceptions to this, but most of them will talk about length of life. I want to be here for this. I want to see this. Keep me alive so I can see these events in my family. And some up front are already focused more on quality of life. But what I see is as time and years go by, quality of life becomes more important than length of life to many of our patients, which is why this trial, I think, is very relevant to that experience.
Yeah, absolutely. And I hope we're succeeding on both fronts with this strategy.
I certainly think we will.
Yeah. I think that when we're hopefully dealing with less disease, smaller clones of disease, less resistant disease, inherently it seems like it's an easier state to treat.
Well, and that's what we're also going to learn, right? What does the disease look like when it becomes resistant to the oral SERD? And what then do we know about subsequent treatments in that setting? And are they the same as what we think now, again, of jumping to an ADC, sequential chemotherapy? It very well may not be. So again, I do think we have to operate in the right now, and right now seems to be about 12-month periods with breast oncology because it changes so fast.
Right.
But if, you know, often we still don't have approval, so once we get approval, it would be lovely to start enacting this routinely.
Yeah.
Yeah.
And it sounds like it'll be part of your practice.
It would be part of my practice, certainly. Would it be part of yours?
I think so. I think it will be a conversation, right, with the patients about what we're expecting and how we'll go about this.
Yeah.
But I actually don't envision it being a difficult sell. I find that our breast cancer patients are often incredibly informed. Like you said, they're aware of this data as it comes out, just like we are in the digital age. They see it, and it's our job to put it in context, right? But I think we're primed for that conversation. And thankfully, by the time we're having this conversation, you know, most patients in SERENA-6, they were a couple years into their therapy before they had an ESR1 mutation detected, right?
Yeah.
So we've established a relationship. We're talking about all sorts of things.
Yeah.
And so I feel like this is also not an abrupt conversation. This is a conversation that I'm going to introduce at some point once they're stable on first-line therapy, but with enough time to say, okay, get comfortable with this idea. We are expecting we're going to find something for at least, you know, 40% of people in your situation. So, and when that day comes, how are you going to respond to that, and how are we going to deal with it? And so it does give you that early peek to say, is this going to affect a patient's life in a negative way when we find it and get that result, or will it be positive for them? So I think that planning aspect of it I really like, because I like knowing what I'm going to do rather than being stuck with the unknown.
Very well stated. Yeah. And it does give a tangible, like you're saying. I mean, patients are actively involved in their care now, and as they should be. And they'll see results as we see results. For them to already know that when that result comes in, okay, like you said, we got this. We knew this was coming.
Yep.
And that's, again, very different. And it's not occasional. It's actually quite common that we see the traditional tumor markers elevating, and we say to the patient, your scans aren't changing, tell me if you have new pain.
Right. That's actually a worse situation.
And that's my point. And they're living with that every day. Like, is this pain the pain?
Yes.
It seems very archaic. It's always, but that is what we do.
It's
and
true.
That's the best we've had.
Yeah. Yeah.
So I am enthusiastic about changing the paradigm.
Which it's unfair to them. A lot of patients say, how am I supposed to know when this is worrisome, when it's not? I think having an objective finding that changes is actually inherently easier. It gives us peace of mind. It gives them peace of mind. And hopefully in an asymptomatic situation.
I agree. And, I was in a discussion with leadership of various payers in the United States recently talking about this and talking from their perspective about how they were considering what kind of oversight, I think is the language was used, they were going to use. Largely, how often are they going to reimburse, for example, ctDNA testing in this setting. And it was interesting to see, again, this isn't a big ask. It's not a large financial ask. And indeed, I look forward to looking at financial data in terms of the cost of life years, the cost of quality of life years, because it's not necessary, in my mind, I don't think that this is going to be a significant additive cost. And in fact, we might see that by giving patients better health and better quality of life for longer, we might end up diminishing overall cost of care, even if the oral agent is expensive.
Right.
Yeah.
Right. I mean, it's true. Paying for the complications that can arise from a progression, that it can be huge, right? A hospitalization for a hip fracture.
And these were the discussions yes.
So one other logistic point about managing toxicity. So you brought up the ocular toxicity. Yeah. How big of, I guess, a practice management step will that be in your practice? Do you envision your ocular colleagues having to be involved in all of your patients?
No. I mean, the truth is no. Yeah. Again, the ocular toxicities associated with camizestrant, they're not structural. They are symptomatic, and they're not functionally impairing. And to really know, I think it's not going to require, for example, having an MD provider, an ophthalmologist. If a patient has some changes, they can see an ophthalmologist, they could see an optometrist, but the reality is it's very different than some of the other agents we're using. When and this isn't breast world, but for those of us who dabble in other disease types, you use mirvetuximab. You cannot miss an ophthalmic exam on that drug, or you can cause real damage to that eye. You can cause real damage to a patient's vision, and that's not necessarily something that recovers quickly. Right. So there's a different type of ocular management, surveillance, and toxicity understanding that comes with other agents in oncology, and that should not be confused in my mind with what we're talking about with camizestrant.
Yeah, that's perfect. I think our comfort level with it will evolve, as it has for so many of our agents. But I think giving that reassurance to patients, know, that it is not structural, that it will resolve, that most patients just adjust to it, and it shouldn't have functional consequences.
So in many of our regions that are underserved, where we don't have easy access to an ophthalmologist for our patients, I don't think it's going to be an issue with this drug.
Right. It wouldn't limit utilization.
Correct.
Yeah. Or shouldn't limit utilization.
Correct.
Great. Well, Dr. Tweed, thank you for a wonderful conversation today. It's nice to be able to put the data into context and think about how it affects real lives.
Yeah, no, thank you for having me. It makes us better as doctors and as partners with our patients, honestly, to have discussions like this, because you make me think. You make me think about my practice now and where we should be going, and I think we should all take this time to really digest data. We don't often have that time, unfortunately. So
Right,
thank you for
right.
having me.
Absolutely. At
Yeah.
the end of the day, we're all figuring it out together. And the insights are all really helpful.
Yeah.
So to our audience, thank you so much for joining us today. We appreciate you.
Thank you.